Good afternoon, everyone. Thank you for joining us at the California Dialogue on Cancer Surveillance Data webinar series. My name is Sheila Sanyo, she/her, Strategic Alignment Specialist for the Comprehensive Cancer Control Program and the California Cancer Registry. Please feel free to introduce yourselves in the chat with your name, pronouns, and organization, and where you are joining from. I'll go over some housekeeping while everyone is typing in your introductions. All participants have been muted, but we will leave the chat open for questions. We'll also have an allotted Q&A after speaker's presentation, and please stay until the end of the presentation to participate in a short webinar evaluation. Again, for those who are just joining us, please type in the chat your name, pronouns, organization, and where you're joining from. The California Comprehensive Cancer Control Program is a CDC-funded program that provides leadership and coordination of statewide comprehensive cancer control efforts. The Cancer Program leads the Cancer Control Coalition, which is CDOC, and is also required to develop and implement a state cancer plan. So currently, we are still implementing strategies from our current 2021 through 2025 state plan. And just to note, we are in the process of revising the next iteration of a 10-year plan. So as a background information, these are the current cancer plan topic areas. CDOC work closely with the Cancer Registry and other partners to implement strategies from surveillance topic areas. The Cancer Program collaborates with the UC Davis CalCARES program on our various surveillance goals. So CalCARES is an acronym for California Cancer Reporting and Epidemiologic Surveillance Program. They have supported key strategies such as ensuring wider dissemination of cancer data by producing culturally and linguistically appropriate cancer reports. In today's surveillance data webinar, a UCD researcher will present one of their published reports. This report informs cancer control and prevention partners about disparities in stage at diagnosis and the quality of cancer care in the state by source of health insurance. Today's presenter, Dr. Fran Maguire, is an epidemiologist with the CalCARES program within the UC Davis Comprehensive Cancer Center, which partners with the Central California Cancer Registry. With the CalCARES team, she conducts cancer research and surveillance using cancer registry data and prepares reports to inform stakeholders and the public about cancer trends in California. In collaboration with Cancer Center researchers, she helps to design and lead research studies on a variety of cancer-related topics. She has a particular interest in disparities in cancer treatment and outcomes by demographic and socioeconomic factors. Fran has a PhD in epidemiology and a Master of Public Health from UC Davis. Please welcome Dr. Fran Maguire.
Thank you for the introduction. Okay, I'm going to share my screen. All right, and put it in presenter view. Okay, and then for the presentation, I'm going to turn off my video and then I'll come back on at the end. Okay, thank you again for the introduction, and thank you for the opportunity to present the findings from our report. Let's see, hold on, trying to advance the slide. Okay. All right, here we go. Okay, so everything I'm presenting today comes from this report that my colleagues and I put together, and it is available on the website that I put the link there on the left. It's the UC Davis Comprehensive Cancer Center website. Okay, so first, a little background on the topic. Lack of adequate health insurance can be a barrier to care and can result in delays in diagnosis and treatment. Studies have shown that uninsured and Medicaid insured individuals diagnosed with cancer have worse survival than privately insured individuals. The Affordable Care Act implementation began in 2010 and had full implementation in 2014, and it really changed the insurance landscape in California. There's been a decline in uninsured, an increase in Medi-Cal enrollment, and an increase in private insurance. So given this changing insurance landscape and findings from prior research, we sought to evaluate the effect of health insurance on cancer outcomes in California. We had two aims for this study, and one is to describe the impact of health insurance type on cancer stage at diagnosis, and two was to describe disparities in quality of cancer treatment by health insurance type. In the study, we included 9 cancer sites, and they were cancers of the bladder, breast, cervix, colon, rectum, endometrium, stomach, non-small cell lung, and ovary. We included diagnosis years 2014 to 2021, and cancer treatments were defined by Commission on Cancer Quality Measures. We used AJCC stage, and we defined early stage as in situ and stage 1 if in situ was available. And if not, we called early stage stages 1 and 2, and late stage was defined as stages 3 and 4. These are the health insurance categories that we used. Private insurance included managed care, health maintenance organization, preferred provider organization, fee for service, and it also included the categories of Medicare with supplement and TRICARE. Medi-Cal included Medicaid fee for service, Medicaid administered through managed care, and Medicare with Medicaid eligibility. Medicare included the categories of Medicare without supplements. Other public included county-funded military treatment facilities, Indian Health, and VA, and then we had an uninsured category. The results are reported by age group, 20 to 64 years and 65 years and older. Patients 20 to 64 years with Medicare were grouped with the other public category. There were not a lot of patients 20 to 64 with Medicare, but anybody with that insurance for that age group we put in the other public category. Categories with low counts, fewer than 50, were excluded from the results. Okay, so I'm going to go through every site and show you a lot of bar charts. So I want to orient you to them first. So this is bar charts showing stage at diagnosis by health insurance type. On the left are the results for the younger age group, 20 to 64, and on the right are for the older age group, 65 plus. You can see on the right it includes Medicare, on the left it doesn't. And then each row are row percentages. So among that insurance category, that is the percentage of each stage. And then the rows will not add to 100 because I'm not showing unknown stage categories. Okay, so let's get started with results. So I tried to color code results because we're going to go through a lot of figures and bar charts. Blue is supposed to mean better, and red is supposed to mean worse. And then underneath each figure is a summary of the results. So this shows that for bladder cancer, for both age groups, the privately insured had higher percentages of early stage diagnosis. So early stage included in situ and stage 1, and you want higher early stage. So privately insured did have higher. And then in the red boxes, Medi-Cal and uninsured had lower percentages of early stage. And for the older patients, Medicare, I put it in a gray box because it was in between private and Medi-Cal. For late stage diagnoses, for late stage, you want to see lower percentages. And for both age groups, the privately insured had lower percentages of late stage, meaning stages 3 and 4. And then Medi-Cal and uninsured had higher percentages. And for the older age group, Medicare was very close to the privately insured. For bladder cancer, there was one quality measure we evaluated, and that was the percentage of patients with at least 2 lymph nodes removed in patients under 80 years undergoing partial or radical cystectomy. And so to orient you to these figures, on the left is the younger age group, the right the older, and the top bar in blue is the total percentage, and then underneath are the breakdowns by insurance category. So you could see overall, both age groups had high adherence to this quality measure at 88%. For the younger age group, more privately insured met the quality measure. For the older age group, the categories are nearly equivalent, and uninsured had the lowest percentage meeting the measure. Now on to breast cancer. For breast cancer, we saw similar patterns with early stage diagnoses. The privately insured had the highest percentage of early stage diagnoses, and those with Medi-Cal or no insurance had lower percentages of early stage diagnoses, and Medicare insured were fairly similar to the privately insured in terms of early stage diagnoses. For late stage diagnoses, privately insured for both age groups had lower percentages of late stage diagnoses, and Medi-Cal and uninsured had higher percentages. Medicare was pretty close to private again. Breast cancer has 3 quality measures we evaluated. The first one is the percentage with at least 4 positive regional lymph nodes where radiation was administered following any mastectomy within 1 year of diagnosis. So overall, roughly 60% of patients adhered to that measure. More privately insured met the quality measure for both age groups. For the older age group, Medicare was nearly equivalent to private, and Medi-Cal had the lowest percentage meeting the measure. The next measure for breast cancer was the percentage under age 70 undergoing breast conserving surgery who received radiation therapy within 1 year of diagnosis. So overall, roughly 70% of patients adhered to that measure. More privately insured met the quality measure for both age groups. For the older age group, Medicare was very close to private insurance, and Medi-Cal and uninsured had the lowest percentages meeting the measure. Now, the third measure was the percentage receiving combination chemotherapy within 4 months of diagnosis for women under age 70 with stage 1B to 3 or T1N0, M0 hormone receptor negative cancer. So overall, you could see the younger age group had greater adherence to this measure, and at 82% versus 72 for the older. More privately insured met the quality measure for both age groups. For the older age group, Medicare was close to the private, and Medi-Cal had the lowest percentage meeting the measure. So now these are the results for cervical cancer. For cervical cancer, for both age groups, the privately insured had higher percentages of early stage diagnoses, and Medi-Cal and uninsured for the younger age group had lower percentages. Medi-Cal had lower percentage for the older age group. And Medicare, I put in a gray box because it was in between Medi-Cal and private for the older age group. And one other thing to notice here is that the younger age group overall had a higher percentage of early stage diagnoses, and the older age group, it was lower. Now, these are the percentages of late stage diagnoses for cervical cancer. And again, overall, you can notice that the older age group had higher percentages of late stage diagnoses. And then for both age groups, the privately insured had lower percentages of late stage, and Medi-Cal had higher percentages. And Medicare was, so in between private and Medi-Cal for the older age group. And they were pretty close together for the older age group, those percentages. Cervical cancer had one quality measure we evaluated, and that is the use of brachytherapy in patients treated with primary radiation in any stage. So overall, you can see it was very low compliance with this measure, 23 to 28%. For older patients, more privately insured met the quality measure, but all the categories are really close. But for the younger age group, the private was the lowest, but also those categories are pretty close. Now the results for colon cancer. For colon cancer, for both age groups, the privately insured had higher percentages of early stage diagnoses, and Medi-Cal and uninsured had lower percentages. Medicare was somewhat close to the privately insured for the older individuals. For late stage diagnoses in colon cancer, again, the privately insured had lower percentages of late stage diagnoses, and Medi-Cal and uninsured had higher percentages. Medicare was pretty close to private insurance for the older age group. For colon cancer, there were a couple quality measures we evaluated. The first is the percentage of patients under 80 years with stage 3 disease for whom adjuvant chemotherapy was administered within 4 months. And the older age group had lower adherence than the younger age group, but for both age groups, more privately insured met the quality measure, and Medi-Cal had the lowest percentage meeting the measure. The second quality measure we evaluated for colon cancer was the percentage of resected cases that had at least 12 regional lymph nodes removed and pathologically examined. For both age groups, more privately insured met the quality measure, while uninsured had the lowest percentage adhering to the measure. For the older age group, Medicare had similar adherence to private, and for both groups, adherence was, roughly 65%. Now on to endometrial cancer. And the results here, you can see for both age groups, a lot of patients are diagnosed early stage, and the privately insured had the highest percentages of early stage diagnoses. Medi-Cal and uninsured had lower percentages, and Medicare was nearly identical to privately insured. For late stage diagnoses, privately insured had the lowest percentage of late stage diagnoses. Medi-Cal and uninsured had higher percentages, and Medicare, again, was very close to the privately insured. For endometrial cancer, we had one quality measure we evaluated, and that was the percentage of stage 3C or 4 cases that had chemotherapy and or radiation administered. So you can see that the younger age group had much higher adherence to that measure at 42%, and the older age group was lower at 29%. For both age groups, more privately insured met the quality measure, while Medi-Cal had the lowest percentage. But for the older age group, Medicare was nearly identical to private. Now, stomach cancer. For stomach cancer, for the younger age group, the privately insured had higher percentages of early stage diagnoses, and then Medi-Cal and uninsured had lower percentages. For the older age group, the private Medi-Cal and Medicare were nearly identical, 23 to 25% early stage diagnoses, and uninsured was lower at 12%. For late stage diagnoses, the privately insured for the younger age group had lower percentages of late stage diagnoses, and Medi-Cal and uninsured had higher percentages. For the older age group, the privately insured, Medi-Cal and Medicare insured were all very close in their percentages, 42 to 44%, and uninsured had the higher percentage at 54% of late stage diagnoses. So for stomach cancer, there was one quality measure we evaluated, and that was the percentage of resected cases with at least 15 regional lymph nodes removed and pathologically examined. Roughly half of the patients adhered to this quality measure. For the younger age group, there was very little difference between insurance categories. And for the older age group, other public had the lowest compliance and Medi-Cal had the greatest compliance, but the categories were pretty close there as well. Now on to non-small cell lung cancer. For non-small cell lung cancer, the privately insured of both age groups had the highest percentage of early stage diagnoses, and then Medi-Cal and uninsured had lower percentages. Medicare was fairly close to the privately insured for the older age group. And for late stage diagnoses, the privately insured had lower percentages of late stage diagnoses, and Medicare for the older age group was very similar to privately insured. Medi-Cal and uninsured had higher percentages, and one thing to note is percentages are very high for late stage diagnoses for non-small cell lung cancer across age groups. All right, there are a couple quality measures we evaluated for non-small cell lung cancer. The first is the percentage of resected, percentage of resected stages 1A, 1B, 2A, 2B cases that had at least 10 regional lymph nodes removed and pathologically examined. For both age groups, the privately insured had the greatest percentage adherent with the measure. For the older age group, there was little difference between the categories. And for both age groups, it was somewhere around 50% that adhered to the quality measure. All right, so this quality measure was the percentage of surgically resected lymph node positive cases where systemic chemotherapy was started within 4 months pre-op to 6 months post-op. For the younger age group, privately insured had the greatest percentage adherent with the measure and Medi-Cal the lowest. For the older age group, there was little difference between the categories. Okay, and then the final quality measure for non-small cell lung cancer is the percentage of cases that are N2, M0, which means lymph node involvement but no metastases, where surgery is not the first course of treatment. So for this measure, it had fairly high adherence. The older age group had higher adherence than the younger age group. And the privately insured had the lowest percentage adherent with the measure for both age groups. Okay, so ovarian cancer results are here. For early stage diagnoses, the privately insured had higher percentage of early stage diagnoses for the younger age group, and then Medi-Cal and uninsured had lower percentages of early stage diagnoses. For the older age group, I put everything in red because there was almost no difference among each type of insurance. It ranged from 19 to 22%, which was, quite a bit lower than their younger counterparts. So not a lot of difference there. For late stage diagnoses for the younger age group, the privately insured did have lower percentages of late stage diagnoses. Medi-Cal had higher percentages of late stage diagnoses. And then for both age groups, I put uninsured in yellow because, actually you can see there, the uninsured looks like they have the lowest percentage of late stage diagnoses, but these are pretty small numbers. It was right at about the limit where we, don't show the results. So it was, I think that it's sort of a factor of a low count there, those results. So I put it in a yellow box. For the older age group, I put all private, Medi-Cal, and Medicare in a red box because they are nearly identical and all, high percentage of late stage diagnoses. For ovarian cancer, there was one quality measure we evaluated, and that was the percentage of stages 1 to 3 cases receiving salpingo-oophorectomy, debulking, cytoreductive surgery, or pelvic exenteration. And roughly 65% of patients were adherent with that measure. The privately insured had the greatest percentage adherent with the measure, and Medi-Cal or uninsured had the lowest. Okay, so now rectal cancer. Here are the results. And rectal cancer, this shows the early stage diagnoses, and the privately insured of both age groups had the greatest percentage of early stage diagnoses, and Medi-Cal and uninsured had lower percentages of early stage diagnoses, and Medicare was identical to the privately insured for the older age group. These are the results for late stage diagnoses, and the privately insured had lower percentages of late stage diagnoses. For the older individuals, Medicare was almost equivalent, and Medi-Cal and uninsured had higher percentages of late stage diagnoses. There was one quality measure that we evaluated for rectal cancer, and that was the percentage where chemo and radiation were administered pre-op or post-op within 180 days for stage 3 patients under 80 years of age. So adherence was low for both age groups, and categories were very close to each other, so not a lot of difference for that measure. All right, so that is all sites I've gone through. So in conclusion, generally, patients having Medi-Cal or no health insurance were diagnosed at more advanced stages and had lower compliance with quality measures than those with private or Medicare insurance. And as you saw, Medicare was very close to the privately insured for many of the measures and stage at diagnosis. There were some limitations to the study. This is purely descriptive analysis. So we just showed percentages. We are planning a more robust analysis and doing modeling. So stay posted for that. And also for some of the measures, we could not determine all the details of the measures given what is available in registry data. I want to acknowledge my co-authors on this project. I had a lot of help with this. I didn't do it alone. So I want to acknowledge everybody else who worked on this project with me. And with that, thank you. And I'm happy to answer questions or entertain any feedback. I appreciate that as well.
Thank you so much, Fran, for your insightful and comprehensive presentation. I'd like to now open the floor for any questions. And I see a couple of questions on the chat. Albert Farias, do the optimal rates of patients receiving commission and cancer concordant treatment reflect real quality deficiencies or completeness of treatment data in CCR? Example, radiation therapy versus chemotherapy versus surgical therapy.
Okay, I'm not sure I understand that question. So the question is, does it reflect what was in the CCR data? Could you or do you
Yeah.
want to say, yeah, go ahead.
Yeah. Hi, Fran. Thank you.
Hi.
Yeah, thank you, Sheila, for translating my question. Yeah, I'm interested in wondering if these are real deficiencies in quality. So since some of the adherence to the COC recommendations were pretty low, or is it that we don't have complete data on radiation up to 1 year after the date of diagnosis?
Yeah, that's a great question. And, honestly, I don't know the answer. I mean, yes, of course, it could be the data that maybe we aren't picking up everything. And some of or all of the measures were very detailed. So that's a great question. And, definitely it could reflect deficiencies and how we are interpreting the measures. And as I mentioned, the limitation, a lot of the detail is really hard to figure out with the registry variables to make it exactly like what the measure is saying.
Yeah,
So
I know.
that's a great question.
Yeah, and I know that like the initial line of therapy is pretty complete for the data abstraction, but once you get, and there are data that look at the validity of this with the claims data. Once you get to chemotherapy and radiation that happens at month 8, et cetera, it's less complete in the record.
Yes,
And so
that's
we have to be very
true.
careful when interpreting these. They may be underreports, I'm assuming,
Yes.
actual adherence, but yeah,
yes, and I think we do know that in particular radiation can be hard. There could be an underreporting of radiation in registry data.
Yeah, and a lot of the COC measures were on radiation and
Yeah,
radiation.
right.
Great, thank you, Fran.
Thank you.
We have another question from Stony. What should we do to help medical improve their performance in cancer screening and treatment? This is critical since 15 million Californians are insured by medical. This is about 35% of Californians insured population.
Yeah, that's another great question. And, I always hate seeing results where Medi-Cal looks bad. And I know the findings I showed, it made Medi-Cal look bad. But I think it has to be taken into context as well that it's not necessarily that, Medi-Cal providers are bad, but I think it's there are a lot of barriers to care that Medi-Cal patients face. And one is I think it's a month-to-month enrollment. There's paperwork involved. There's barriers to getting to care. Possibly not enough providers in Medi-Cal. I think there are a lot of issues in the population that is Medi-Cal treated. So that's a great question. And yeah, I would love to know exactly what the barriers are because we do see this in the data a lot. And yeah, it's true. It does serve a large population in the state. So yeah, more research.
Go ahead. Just expand on that a little bit. This is Tony. Sorry. Yeah, they're a very large group. They do have a council that meets monthly of the medical directors of all the Medi-Cal managed care health plans, which are most of Medi-Cal. I think this report should be given to them. Have you got any plans to do that?
No, I mean, it is posted on the website. No, we don't have plans to do that. We do want to do a more robust analysis, as I mentioned, because this is purely descriptive. So yeah, that's a great idea to discuss further with like who you mentioned to try and understand better what exactly is happening that makes Medi-Cal look so much worse.
Well, for colon cancer, we know because we finally got them to measure it, and they're screening at 37%, which is, terrible screening. Their cervical and breast cancer screening is a little better. It's in the 50 percentiles. But in colon cancer, we've known for years that having Medi-Cal insurance as far as late stage diagnosis was the same as being uninsured. So I think reinforces that things have to change. And I know it's difficult and reimbursement rates are low, but still things have to change because it's such a big portion of our California population.
Yeah, I agree. Yeah, those are great points you brought up.
So mainly I'd love any ideas of what else we can do besides present to the medical directors. Is there any, should we get the legislators involved with this data? Should there's not a cancer caucus in the legislature, but there is a cancer caucus that meets, and we'll be talking to you about this presentation about that, because that'll be in the spring. We could show something like this.
Yeah, it would be great to get input from other stakeholders and try to understand that better.
Do we have other questions? I see a follow-up comment from Albert. Language SES barriers, it's very complex. Hearing no other comment and questions, I'll go over and wrap up. Please take a moment to complete a short webinar evaluation, which I will be sharing on the chat. And today marks the first surveillance webinar for the fiscal year 2024-2025. Thanks again, Fran, for presenting today. We'll have more wonderful presenters and topics on the dates listed on your screen. And any recording and slide deck will be shared with you via email. So if you have any follow-up questions with Fran, feel free to fill it in on the webinar evaluation. Thank you all so much for joining today and wishing everyone happy holidays.
Thanks, everyone.